we've got a lot of data that we're generating.
Nitinol roughly doubles every 5 years. The use of Nitinol in medical doubles roughly every 5 years. So you do the math there, that's pretty good double-digit growth.
That's fantastic. That's fantastic.
Here's a smaller size stent.
Mm-hmm. That's awesome. Chinese finger trap, huh?
Everybody was excited about bioreabsorbables for stents that disappear. And because of those complications, it was pulled off the market. And for like a decade, Spencer, nobody was really interested, or very few people were interested anymore in bioreabsorbables. So kudos to Abbott for getting this new bioreabsorbable stent on the market to treat peripheral artery disease.
That's the nature of innovation, right? Like you have to fail to some degree and you try again, and that's what keeps us moving forward.
I love this conversation because you have that real world experience, right, in the cath lab and such, and can kind of connect the dots here.
This is why we do what we do. This is why the medtech people say, hey, we want to do innovative stuff. The why at the end of the rainbow is so we can help patients. Hey everyone, Spencer Jones here, host of the MedTech Innovation Podcast. Thank you for joining us for today's episode, backed by very popular demand. I had a lot of people tell me how much they loved it. And I was like, me and Steve are already planning the next one. But we've got Steve Maxson with us today. Steve leads innovation and business development at US Extruders. He's also the owner of Maxson Insight Services and the host of the MedX podcast and the MedTech Unbox podcast, which if you haven't checked it out, you got to do it. It's super awesome. He's got over 20 years of extrusion technology and medical device manufacturing expertise and assists contract manufacturers and med device OEMs with extrusion, secondary processing, equipment, and manufacturing services, and is also just a wonderful guy that I got to meet at MD&M, which was super awesome. But Steve, welcome back to the pod.
Thanks, Spencer. Appreciate the kind words. It was really fun last time, and it was also great to kind of meet you face to face at MD&M West. That was a great show.
I know, it really was. That was my first time going. I know it was not your first rodeo going out there, but it was a blast. I think the scale of it was just like massive and incredible. And it was just like, I've been to a lot of surgeon focused trade shows, right? Or nurse focused trade shows and all that stuff kind of on that sales side. But this one was just totally unique. And I saw some of what we're going to talk about today out there, and that was very intriguing to me. But the last pod we did was really focused on that hot stuff, right? That energy delivery via balloons, right? RF and pulse field ablation and all of those things. So today we're going to kind of take in a little different direction, but still talk about the delivery of something, but the delivery of stents, right? Whether it's balloon expandable or self-expanding stents. I know this is something that is fascinating to me. I know it's something that you've got a ton of experience with. So why don't you go ahead and kind of walk us into it, talking about balloon expanding versus self-expanding stents.
Sure. I think it's a good continuum from our last discussion, which was pretty cool about the delivery of energy, or balloon-based delivery of energy for ablation to treat AFib, and also renal denervation to treat hypertension. There's just a lot of money, time, and effort going into that space. It's very exciting. Alternatively, when we talk about delivery systems, we were talking about delivery of energy, and the last time around, we're going to talk about the delivery of devices or stent scaffolds. And so, and we'll talk about some of the materials that are used and some of the therapies. I think it'll be hopefully an informative discussion.
Yeah, I agree. So for the people that may not be as much of an expert as you on these things, just walk us through kind of the basics of stents, what they are, what they do, and we can kind of evolve it from there.
Yeah. So stents can be small or large. Here's a smaller size stent.
Mm-hmm. That's awesome.
Yeah. And
Chinese finger trap. Huh?
Yeah. And this is the sample that was provided to me by Miko Manufacturing in Germany. It's a demo of what the possibilities are to laser process a heart valve stent. This is really wicked cool.
Yeah, that's awesome.
Yeah. So they're typically used to treat a narrowing of a vessel or an artery or a weakened artery. And they're made from specialty metals like stainless steel or cobalt chromium alloys or nickel titanium, which is nitinol. And we'll talk a lot about nitinol today because it's such a magical material. And are also polymeric stents, and that's kind of an interesting topic as well. I'm going to share my screen here.
Yeah, please. Yeah. No, the nitinol piece, super interesting. I mean, even in some spine applications, right? Things I've been working on, we've been looking at nitinol for those. But yeah, go ahead.
Yeah, we'll talk about nitinol, but so many different applications for medical,
Yeah.
and the majority of them for medical and nitinol is for implantable stents. So we're going to be talking about some of these, but back to the polymeric stent. It's pretty interesting kind of history, evolution. More recently, Abbott released their below the knee bioreabsorbable stent. So this is a polymeric stent made from a PLLA, polylactide type material with a drug coating to prevent inflammation, probably thrombosis. And you can see there's some marker bands, typically on the distal and the proximal. So this stent will do its job mechanically to allow blood to flow within the vasculature, deliver the drug, and ultimately just disappear. And so this is kind of a breakthrough. And I said there's an interesting story because back in like 2016, Abbott came out with the first bioreabsorbable coronary stent. And it was FDA approved and it was on the market, but very shortly after it was pulled because there were some complications. And that was like $1 billion investment. Everybody was excited about bioreabsorbables for stents that disappear. And because of those complications, it was pulled off the market. And for like a decade, Spencer, nobody was really interested, or very few people were interested anymore in bioreabsorbables. So kudos to Abbott for getting this new bioreabsorbable stent on the market to treat peripheral artery disease.
Yeah. No, and that it's really fascinating. And I think that story of, things being tried and them not working perfectly or them having to pull it off the market, and then kind of investors, because I think the innovators are still interested, right? But even the investors in the capital side are like, I don't want to touch that. We saw this and we saw it fail.
Yeah.
I think cartilage repair has seen the same thing. There's been a lot of people trying to do it. And there's been things that have worked somewhat, but a lot of things that didn't work. And so I think I've seen, at least in that space for sure, right, a little bit of gun shy around that. But it's like, that's the nature of innovation, right? Like you have to fail to some degree and you try again, and that's just what keeps us moving forward. But that's super interesting, and embedding those biomarkers, and then the drug-eluting to prevent that hyperplasia, right? With that intima layer of the vessel. Super, super, super fascinating.
Yeah, and it really takes grit for some of these people to stay in it after that failure. Maybe failure is kind of harsh, but even some of the contract manufacturers that develop some of these polymers, a company in South Carolina called Polymed, Zeus. Zeus is big into developing these bioreabsorbable polymers so that these stents that disappear over time can be developed. So good job for those people to stick with it.
Yeah. So I totally agree. I mean, it's like those people, those critical people in the supply chain, which also play a large role in the design and development, oftentimes too, right? But those people cannot be forgotten, and it's kind of hard, like, to just like have that ecosystem that just turns on whenever somebody just has that idea, right? They had to kind of have that long game, and I think their understanding and expertise of the technology, they probably knew all along, like, they're getting a bad rap, right? These bioresorbable stents, but they will be back, right? And they kind of like held into it. So what, thinking about like one stent versus another stent, right? Like, what are the properties that people really look for to like say, like, what are the metrics they're graded on? I guess another way to say it.
Yeah, good question. There's a couple of the properties that I'll go through for a stent. And the first one is the radial strength, the outward pressure or force. So if there's a lesion, calcification, plaque within a vessel, you want enough radial force to push that plaque against the wall of the vessel so that blood can flow, right?
Yeah.
And so opposite of that is the hoop strength, which is basically the ability to prevent this from crushing. We've got the outward force, radial, hoop strength, and it has to be very flexible, right? So
Yeah.
that we can navigate the tortuous anatomy and cross very complex lesions.
Yeah.
And like you mentioned earlier, there's typically some radio-opacity added to it, crimped or swaged marker brands on the distal and proximal ends so that you can see the stent under fluoroscopy. So those are
Yeah.
some of the properties that you want to look out for. And some of these stents also, Spencer, are covered. There's coverings on them. I'll give you an example. Here's a stent
Oh, yeah.
with a covering just on the inside. And the covering is so that there's less trauma on the vessel. And in some cases, so that there can be cell growth for healing, natural healing.
Yeah, because I could imagine like when you're going in there and kind of deploying it, right? You're really pushing on that artery, right?
Hmm.
Artery or vein. And that vasculature, like that intima layer especially, is very sensitive. You know what I mean? And back from my vascular access days, right?
Yeah.
We would even look at, in the peripheral vascular when you're putting in a catheter or when that catheter is wiggling around in the vein, right? Like how much is it scraping and scratching that intima and then causing that cascade of fibrinogen. And like for the catheters, it was like depositing biomaterials,
Yeah.
right? And we were kind of trying to prevent against this, but it is very sensitive. So you got to think about that healing element to it. And now just to kind of call back to the last episode, you could use these stents in combination with kind of an ultrasound sonification to break down that plaque. Am I thinking about that the right way?
Yeah. Yeah. I mean, I love this conversation because you have that real world experience, right, in the cath lab and such, and can kind of connect the dots here. One
Right.
more example I wanted to share on the covering. This is more like a TAVR type heart valve frame, and there's a covering on the inside, and you can see that skirt, Spencer, on the outside.
Yeah.
So that's for sealing between the aorta and the actual stent frame to prevent leakage.
Mm.
And then
Hmm.
there's another one is just fully encapsulated,
Yeah.
right? And so these coverings could be of expanded PTFE membrane for cell growth, polyurethane, silicone coatings, or like an electrospun PET material.
Yeah, that's really interesting. Yeah, I was almost when you were when you were talking about like atrial, you're going to have a lot of flow, a lot of pressure, so that sealing strength to prevent leaking is really important. For some reason, where my head went to was like, when you're putting on like a new shower, like a shower head, you got to
Yep.
put the little wrap around it. That's where my head went for some
Teflon
reason.
tape. Yep.
Yeah,
Good
gotta put that
example.
tape on.
Yeah.
So yeah, so I want to kind of go back if we could to like the nitinol piece and maybe just kind of like walk through walk through a little bit of time or like how it's developed, how it's grown, because like I think that use of nitinol's probably been one of those kind of like quantum leaps in like what these things are able to do, if I'm thinking about it correctly.
Yeah. I mean, nitinol is just a magical material, Spencer. That's what a lot of people call it because it has this super elastic, highly flexible nature to it. Again, so that we can track through the tortuous anatomy, cross complex lesions, this amazing shape memory characteristic. So when it's preformed, set in a mold during manufacturing, and then when it's delivered, it'll always go back to that preset shape.
Mm-hmm.
Of course, it's kink resistant, crush resistant, and biocompatible. And the growth in nitinol, not only in stents, that's the major, implantable stents is the major application, but in all these other types of applications, it's just phenomenal.
Yeah.
And I did a podcast with Joe Mullins, and we
Mm-hmm.
had Dean Shower as a guest. Dean is the CEO of Confluent Medical, one of the largest producers of nitinol and nitinol components, implantable devices. And Dean said that nitinol roughly doubles every 5 years. The use
Oh,
of
wow.
nitinol in medical
Yeah.
doubles roughly every 5 years. So you do the math there. That's pretty good double-digit growth.
It really is. I mean, that tracks a lot with like what we're seeing from like that kind of electrophysiology market broadly, right? I'm curious, about the shape memory. I could see in the stent world, like that shape memory around, we want it to be here, or we want it to, go in here and then rebound to there. That's the shape, a lot of the shape memory we're talking about, right? But I'm curious, is there patient-specific implants, right? That's becoming more and more of a thing where it's like you're getting kind of topographically, what are the end plates? What's the lordosis? How do we need to design this implant, whether it's cervical, lumbar, or otherwise, to be designed for that patient? I'm curious if there's any, say you're trying to go in and put a nitinol stent in kind of a tortuous or bent path. Is there any patient-specific nitinol stents that are bent to the vasculature as well as that kind of radial expansion?
Are you talking about, specific to a patient?
Yes.
Yeah, that's a good question. I don't know. I don't think so. I think like for a stent, there's different sizes
Yeah.
that the surgeon would choose based on their anatomy.
Yeah.
But that's interesting.
Yeah, trying to find your straight paths, you know what I mean?
Yeah.
And then you can connect the dots with multiple stents if you need to. Yeah.
Yeah.
That's just curious. Yeah.
Yeah. So kind of back on the growth here, this is an interesting chart. A friend of mine, Dr. Vishal Gupta, shared this with me. And if you just look at, just general surgeries, and back in, before, pre-1990, it was more open heart surgeries, right? And then starting in the 90s, you saw the advent of these stents, and just, starting with like 5,000 patients maybe being treated with a stent, and just you could see the rapid rise in the use of stents. So just think how many more patients have been served by interventional cardiologists because of stent technology. Not only stent technology, the whole medtech ecosystem, right? The stuff that we do and all our customers and clients do as well.
No, that's huge. And I mean, I know this, like, I got to imagine this trend probably even maybe accelerated some, right? Over the following years. And I'd love to see this tracked against, cardiovascular, like kind of coronary events, right? Or cardiovascular injuries, right? However they classify that, as well as the morbidity around those cardiovascular and peripheral vascular events and clots and things like that. Like I would imagine that, the advent of this is almost similar to, like lisinopril, right? And the blood thinners. And when those came out, you just saw a massive decrease, right? In the amount of people having those kind of catastrophic coronary events. So no, huge. I mean, and this is really, right, Steve, like what it's all about. This is why we do what we do. This is why the medtech people say, hey, we want to do innovative stuff. The why at the end of the rainbow is so we can help patients, right?
Yeah. We'll talk a little bit about TAVR and transcatheter aortic valve replacement. And that's another biggie, right? And just, I want to share this. You can see this red line when this was introduced, 2012, the growth there. But think about this at $35K a pop, with over 300,000 people being treated with these TAVR devices. That's a $10 billion market, Spencer.
Mm-hmm. That's crazy.
Yeah.
That's crazy. And so these TAVRs, just level set for everybody. So these are being put in to serve as like a full replacement for that aortic valve, because it's getting regurgitation, it's faulty, and you're kind of getting not a full between pumps, right? There's regurgitation and backflow. And ultimately, it probably causes the heart to work harder to a degree too, which can cause some cardiomegaly. And it seems like, when stuff like this comes out and you see that type of growth, it was just like people were like literally dying for a solution. You know what I mean? Surgeons were just clamoring to figure out a way to treat these patients, and then they have it. That's fantastic. That's fantastic. On the stent side, I know you had mentioned there's, I think it was balloon-expandable, right? Versus self-expanding. Would love if you could just like walk through. I think you may have some samples too, but like love to walk through kind of how they work, pros, cons of each, that kind of thing.
Yeah, sure. Let's go through some of these. We'll start with balloon-expandable. Little graphic here just to give an example. This is a Cook balloon-expandable stent, and you can see the stent is crimped on to if you go to the right here, to the balloon body. And then when the delivery system delivers the balloon or stent within the narrowed artery very precisely, it'll be expanded and inflated and to deliver the stent. So that's a balloon expandable stent. Alternatively, there's self-expanding stents as well, where the stent is loaded within a sheath and it's basically unsheathed. Mm-hmm. So there's kind of pros and cons of each. style as well as different, applications for each. I think balloon is mainly in the coronary, and self-expanding is kind of beyond coronary, carotid and such. I don't know exactly all those different
Yeah.
placements, but that's kind of in a nutshell. And so there's kind of pros and cons of each, really. The balloon expandable stent will be more precisely delivered within the area or of stenosis, for instance. And it's typically just one diameter, though. It's not. It's kind of like something like this, a straight diameter,
Yeah.
versus kind of a more complex design like this. That would be a self-expanding stent.
Gotcha. Yeah, no, that makes sense. That makes sense. Yeah.
And it's a little bit more rigid and less conformal to the vessel or the anatomy, where the self-expanding stent could be better, is more flexible, can go more within the tortuous anatomy and is more conformal
Yeah,
to the
that makes
anatomy,
sense.
but it's not as precise in the placement.
Yeah. No, I could see that. I mean, anytime you're like unsheathing that, right? There's kind of force that's being generated and you're kind of like it's releasing it versus like placing it, right?
Yeah.
Setting it almost. No, that makes total sense. I could see like especially, when the narrowing gets to a certain point and you really want to kind of almost break it open a little bit, right? You really want to
Mhm.
expand that. I could see like the balloon delivery being really key there. Yeah, I remember this was 10 years ago. I was like visiting a facility down in Texas,
Mhm.
and one of their calling cards was they cut their teeth on their expansion force, and what their balloons could tolerate was like 2.5 times like higher than what the leading thing
Mhm.
on the market was, which is a huge deal when you're trying
Yeah.
to bust open an artery, right? And or a vessel, to try to get a stent in there. It's all these, little incremental innovative advancements, the opening strength or the opening diameter,
Yeah.
right? Or the this, that, and the other. And when you piece all those things together, right? The hoop strength, the radial strength with this expansion on the balloon side, you get some like pretty innovative stuff.
Yeah. And then I wanted to share two examples of each. And then I'll actually get a catheter out and share too. But
Nice.
this is the Sapien from Edwards, the balloon expandable stent. And you can see again the stent is crimped on the balloon. The delivery system very precisely orients the balloon and stent relative to the valve, the aorta, and then the balloon or the stent is deployed with the balloon.
Yeah, that's
And
awesome.
so then the alternative would be a self-expanding stent. This is the Evolute, from Medtronic, which is a self-expanding stent. And there was recently a study that was done by the American Journal of Cardiology. You have to check that, and maybe you could put a link. But
Yeah.
they compared a 5-year study, roughly 500 people, endpoints, all-cause mortality, thrombosis, blood clots, etc. And literally, it was very similar result.
hmm Yeah, no, I did. I checked out that study. It was, and they even looked at like conscious sedation versus like general anesthetic, right? Too.
Yeah.
But it was pretty interesting, kind of the similarity between the two. And I'll have to double check. There was something else that was interesting. I want to say in that data, maybe it was around like the general anesthetic versus conscious
Yeah.
sedation. But no, I thought it was interesting. It's like these two. I mean, like fundamentally, kind of the endpoint is you're getting to the same endpoint with both. But that application, I thought that was going to be a bit more of a significant difference between the two when I started reading the study. But no, that's super interesting. And I guess like just on that skirt, visualizing it on that frame, like that
Mhm.
skirt, it's not as much maybe immediately sealing around that kind of like that valve interface with the
Yeah.
skirt. Like it's really providing some healing and integration effect that is above and beyond what you would get with kind of a naked stent. Is that correct?
Yeah. Yeah. So I have a couple examples here I was going to share. We're going to give it a shot. Here's a drug-eluting balloon expandable stent system. And so I'll open this up and see if I can share. I can't inflate the balloon, but I can share this device with you. It's always cool to have. And thank you to my friend who sent this to me. It's always good to have real devices, right?
Oh yeah. Oh yeah.
So
There we go.
So there's always a protector that's usually
Right.
polyethylene or HDPE, and you can see a little flare on it too, so that's not
Yeah.
going to damage the stent. Very hard to see, but there's a crimped balloon or a pleated folded balloon with
Yep.
a a stent that's crimped on top of it. If I could blow it up or put some saline or water in it, it would be really cool, but I can't. But that kind of gives you an idea of this balloon expandable device.
That's awesome.
Maybe if I take this core wire out, you can see a little bit. Yeah, you can see the tip.
Yep.
Maybe. I don't know.
Yeah, it's just no, that's awesome. And it's just kind of, I love that you have one in front of you, because like we see these pictures and we see them blown up and all of this stuff, but when you really get down to it, they're so small. It's just so incredibly small and fascinating.
So then now I have a carotid self-expanding stent system here, and let's see if I can. You can see I deployed it a little bit with the handle, and you can see the stent unsheath out of the sheath there. And something that you might notice, the amber color of this sheath here, right away that tells me that's probably polyimide. Right? So we talked about radial strength, and we're crimping and loading this stent into a sheath, so there's this constant radial force against the ID of the sheath. So if you use a material that's soft, like maybe a film cast PTFE or even extruded PTFE, depending on the radial strength, it'll dig into that inner sheath, and it'll be very difficult to deploy. We talked about the self-expanding stents being not as precise in deployment. That's possibly one of the reasons. So polyimide is really super strong. I think it has the highest tensile modulus of any polymer, but it's also scratch resistant. This might have a PTFE inner liner, but so that's what I think that this sheath is a polyimide. So let's go ahead and I got the handle here.
Yeah, that's interesting. The handle.
I'm just a sales guy, but let's just see what we can do here. All right, so I'm gonna try to deploy this. I think we got a good angle, right? I'm gonna push this handle down. It's in the go position. And let's see what happens here. Yeah.
Oh, there it goes. Wow.
Lost it.
Yep.
It's on the floor somewhere, but that was pretty cool. It worked.
That is awesome.
Yeah.
That is awesome. That's really cool. Man, the expansion, just like the radial travel of that expansion is like pretty wild. I mean, it's like, if you go diameter to diameter, right? It's like 5x as big, maybe more, it looks like. That's huge.
Yeah.
That's huge. Yeah, it's an interesting, where my head went when we were looking at both of those two was thinking about kind of the packaging and shelf life stability, because they're both non-zero, or like they're not time zero in the sense of like, you package it and it's in some state. They're both kind of like bent or crimped in that state. And so I think that's why that sheath, the poly sheath that you were polyimide sheath that you were talking about is so important. But I think that's like a good thing for people to just kind of think about in terms of like when you're designing and building a product, like if it's sitting on the shelf and something is bent or pushed or a valve is open and you need it to close later, right?
Yeah.
You have to really think about all those things, because like I could imagine getting a 3-year shelf life on something like that is like really tough, right? So like what do you push for? What are the trade-offs? If you want to just do 1-year shelf life, then like what does that do for inventory?
Right.
And your lead times have to be, but anyways, that's where my head went immediately. We dealt with that with a separate product where there was like on the shelf, there was a valve being collapsed and we needed to bounce back. And it's like, not every valve's great at that. You know what I
mean? No, that's a great point. All these polymers, metals, everything has the additives that we put into some of these polymers for value add. There's always a shelf life associated with it. So that's a good point.
Yeah.
And as far as the cost of some of these, I don't really know a lot of that, but I asked somebody that example we shared, the Sapien versus the Medtronic TAVR frame, and I think the pricing is relatively the same.
No, that makes sense. That makes sense. And after kind of just seeing it too, like the use of the self-expanding in the cardiac makes total sense to me, just because like I feel like you don't want to over aggressively like modify the anatomy with like something that's like blowing up. You know what I mean?
Yeah.
So I could see why it's maybe preferred there. That would like make sense to me. But this has been so fascinating, Steve. I feel like I learned more today about these than, it's been a long time since I've been in the cath lab.
Yeah.
You know what I mean?
Now the challenge is, what are we going to talk about next, right? That's fascinating.
Oh, I know. We'll find something. Yeah, no, it's a kind of a similar topic. I was just talking to somebody the other day from J&J, and they were talking about how for a lot, because there's a lot of imaging and, registering and then referencing around the ablation. And there's also like there's a lot of still nuance and subjectivity to the way that people are ablating things. You know what I mean? Especially in kind of that, like, you're trying to get rid of an AFib. So you're going to go in and ablate certain parts of that. And they were basically saying, like, we have the data today. And by the way, this is not like J&J saying this. We were just kind of musing, me and this person. But it was kind of like this conversation of like, we've got a lot of data that we're generating, right? And a lot of the mapping of like where we're hitting with the ablation catheter and not, and all this stuff. And it was like, there is probably a quantitative way to tell us exactly how, maybe even based on that patient specific electrophysiology and anatomy, right? Like that we can track. But like, we've got to like kind of get the data, understand it, and then implement some types of procedural guides and techniques to kind of better inform exactly how, because it's, and the doctors know what they're doing. Don't get me wrong. Yeah. But like, it's always when you can attach some quantitative data to help guide a surgical procedure, exactly when, exactly how long to pulse, exactly what amplitude, right? It's always better. So like, that's I don't know, maybe we could talk about that. I know we will figure out something else to talk about though later on. But well, Steve, I'm so glad we did this again. This was like, as always, fascinating to talk to you. Anything kind of, we'll put all the stuff that we talked about in the show notes, how to get in touch with Steve, how to get in touch with me, all of that. But like, any parting words of wisdom, anything you want to plug kind of on the outro here? No,
I just kind of think back. I'm still thinking back to that chart where I saw all that growth, right? And the increased number of patients being served. And again, it's all because of this ecosystem that we're part of. Minimally invasive procedures, less time in the hospital, less trauma, being home in your own bed, sleep in your own bed, being with your family, literally maybe the next day or the same day. The minimally invasive technologies will continue to grow, and there'll be a lot more to talk about between us in the future.
Dude, amen. Well, until next time, it was awesome to have you, Steve. Thank you, everybody, for tuning in. Hope you guys got something out of it, because I know I did. But have a great day, everybody.
Thanks, Spencer. Thank you.